Hello, everyone. Thank you ever so much for joining us. As Molly said, I'm Julia. I'm one of the support team at Overactive. So if you ever need any information, if there's anything we can help with, if you want to talk something through, then you can get in touch with us via our support line, through our instant chat facility, through emails. And we're here to help you. And today we have a webinar with Katy Megson, who is a physiotherapist, who's here to talk to us about women's health, physiotherapy, and pelvic floor health, which I know is a very important topic for a lot of people that we speak to. So we're really pleased to have Katy with us today. Katy's going to talk to us for maybe sort of 30 or 40 minutes, and then there'll be about sort of 20-30 minutes for questions at the end. So do submit those through the Q&A function that Molly just showed you, and I will ask them on your behalf, and your questions will be anonymous, so I won't read out your name. And again, as Molly says, if we don't have time to get to all of your questions now, if there are any questions that Katy can help with afterwards, then we'll send those to her and we'll circulate her responses later on. And I think that's everything from me. I will hand over to Katy. Thank you ever so much again for coming to talk to us.
Great, thank you. Hi everyone, nice to meet you all virtually. Thank you very much for your tech skills as well, Molly. Hopefully won't need you too much. So I'm Katy, I'm a women's health physiotherapist, and I work at University College London in kind of Euston full time, and I also work privately down in Balham. So it's a pleasure to speak to you today about the kind of role of women's health physiotherapy in both urinary and sexual health, and hopefully give you a bit of an insight in what physio can do to help with some of these issues. As Julia and Molly said, please do let us know if you have any questions. I'm more than happy to answer them afterwards if there's something you think of later on as well. So what we'll cover today, I'll introduce kind of what women's health physiotherapy is, talk through pelvic floor muscles, what they are, where they are, and how to use them. The prevalence of some common pelvic floor muscle dysfunction that we see in clinic, and what physiotherapy can do to help, and what to expect if you do feel like you need to see a women's health physiotherapy, what to expect from treatment or assessment. So women's health physiotherapy. I'm sure lots of you have maybe seen a physiotherapist yourselves before, and you'll know that we specialize in the function of muscles and movement and optimizing physical functioning. And in the specialty of women's health, we're exactly the same, except we focus on the pelvic region. And so that will include your pelvic floor muscles and bladder and bowel dysfunction, and also sexual dysfunction. And common conditions that we see are incontinence, both bladder and bowel incontinence, urgency, both from the bladder or bowel, prolapse, which we'll talk about today as well, voiding dysfunction, so difficulty with emptying the bladder or difficulty with emptying the bowel, and sexual dysfunction, which can be a range of symptoms, either pain with sex or difficulty in having penetrative sex. We do also see women during pregnancy for musculoskeletal conditions, so for things like back pain, pelvic girdle pain, and any pelvic floor related conditions they may have during or after their pregnancy. So we do see women throughout all the kind of life stages, from pre-pregnancy to perimenopause, menopause, and into older age. We do also see men, so technically we're called pelvic health physiotherapists, but for the purpose of today's presentation, we'll stick to women. All the aim of what we do is individualized. So it's very much on kind of specific goals, restoring quality of life and improving function. So it's always kind of based on the individual symptoms and how they affect your quality of life. So there we go. Moving on then to the pelvic floor. So I've got my pelvic floor model in front of me. It's much bigger than we imagine. So there's actually 8 muscles in total. I think sometimes people think of the pelvic floor as kind of one muscle. But if you can see the model here, you've got your pubic bone at the front. At the back, you've got your sacrum leading onto your coccyx, your tailbone, and then you've got the bigger pelvic bones, the ilium at the side. If I turn the pelvis upside down, hopefully you can see there, everything pink in the middle is your pelvic floor. So it's much bigger than we imagine. It's about the size of 2 hands, and it forms that kind of bowl-like structure. There are 3 different layers to your pelvic floor. So the first layer that we see more from the outside, you can see there, is all important for kind of sexual function. And then you have your deeper layers, which are really important for supporting pelvic organs, and also for bladder and bowel function. So it's not just kind of one little muscle, it's a kind of range of muscles. And it's not just the muscles that are important, it's also ligaments and the ligamentous support, the nerves that go to those muscles, and also fascia. So fascia is something that's kind of connective tissue that we have all over the body, but we have particular thickenings or areas where there's kind of more of that fascia, and that's really important for structure and support around the pelvis as well. So I think I've kind of spoken through most of what the function is there, but you can see from the destructed diagram at the bottom that we've got those different parts of the pelvic floor and the different layers. So we've got the sexual function from the outside, the deeper layers supporting bladder, bowel, uterus, or if you had a hysterectomy and your uterus is removed, it supports the top of the vagina. The pelvic floor also forms part of our core, which we always refer to, or you've probably heard lots of kind of terms about the core and the core stability. So that will include your paraspinal muscles, so muscles that run either side of your back, your deep abdominals, which form a corset all the way around the back and the front, and your pelvic floor muscles along with a diaphragm. So the pelvic floor is important for that core support that provides support for your lower back and your pelvis as well. Pelvic floor supports your urethra at the front, so particularly when we have increases in intra-abdominal exercise, so things like sneezing, coughing, laughing, that pelvic floor will provide a closing pressure to the front to reduce any leakage or stop any leakage when we do those activities. It's also really important for urge, and I'll talk more about this later on, but actually exercising your pelvic floor or activating your pelvic floor can reduce contraction that you have at your bladder muscle, which is your detrusor muscle, and it can actually reduce that contraction in the muscle, so it can reduce urgency symptoms with your bladder as well. It's also important for your anorectal angle. So that's an angle that we have in our bowel that maintains bowel continence. And most of the time, this particular muscle, the puborectalis, which I'll show you later, stays switched on to provide at that angle. And when we have weakness there, sometimes that angle can be a bit less and can cause some issues there as well. So that's kind of a bit of a overall of what the pelvic floor does and why it's so important. So what causes a weaker pelvic floor? One of the biggest risk factors is pregnancy, and that's not just because of the pregnancy hormones, it's also because of carrying baby weight over the course of 9 months, so having that extra pressure on your pelvic floor. Childbirth as well, even if you've had a kind of history of a C-section in the past, actually having the pregnancy, carrying baby weight for those 9 months will still affect those muscles. Menopause, and menopause is a big one and lots talking about at the moment. The reduction in estrogen after the menopause has a big effect on the muscles, particularly around the pelvis and the pelvic floor itself. And therefore we can find that we have a weakening of these muscles at that time and the onset of sometimes pelvic floor muscle dysfunction around perimenopause and menopause. After surgery, there can be a weakening of these muscles. Sometimes with surgery, we have less of the supporting structures, so the ligaments, the connective tissues I was mentioning earlier, and this can put us at higher risk of having problems with prolapse, bladder and bowel dysfunction because of that reduction in support as well. If we have a history of respiratory conditions, so things like asthma, or kind of COPD difficulty with coughing lots, then that can put extra strain on the pelvic floor muscles and again can cause weakness. And that's similar to kind of things like constipation where we're straining lots or feeling we have lots of pressure on top of those muscles that can also cause weakness. Aging, so aging, we have the menopausal changes that I've mentioned about the declining estrogen, but also with aging we have a reduction in muscle mass and therefore a reduced support. And genetic factors and soft tissue disorders. So some people are more flexible than others, and if you have kind of certain genes that make you more flexible, you will naturally have more flexibility in your pelvic floor muscles as well. Lifestyle factors. So if you are someone that has a very active job, you're doing lots of heavy lifting, then you're naturally going to be putting more pressure or more weight through your pelvic floor every day. So you almost have to have a extra strong pelvic floor to be able to offset some of that increase in intra-abdominal pressure. The same if you're obese. So with BMI, you're aiming to have a normal weight. If you find that you're overweight or you're obese, then you will be putting more pressure through your pelvic floor muscles, and the pelvic floor can be very sensitive. So therefore, more at risk of having problems with bladder or bowel dysfunction if you do carry extra weight. Smoking is just there because nicotine can irritate some of the tissues in the bladder, but also if you're coughing lots, then you're more likely again to have that increase in pressure on your pelvic floor. So I don't mean this slide is to highlight the prevalence of pelvic floor muscle dysfunction. And I think that's important because it's still such a taboo. So lots of women and men experience these symptoms with bladder dysfunction and bowel dysfunction and pain in the area, but lots are kind of not talking about it and feeling that it's an inevitable part of aging, inevitable part of having surgery. And it's really important that we are talking about these things so people know that there is help out there and there's lots of things that we can do. So just to highlight some of the things, 34% of women in the UK are living with urinary incontinence, so 1 in 3. So if you think about your family and your friends, I'm sure someone has experienced urinary incontinence at some point. 50% of women that have had a child or a delivery will have symptoms of pelvic organ prolapse. 70% of people don't seek treatment, so they don't seek help. And those people that do seek help, it takes them a very long time. So they've often suffered with these symptoms for a long time. So on average, it takes women 6.5 years, which is a huge amount of time. And these things have such an effect on your ability to participate in day-to-day activities, whether that's seeing friends, being physically active, being sexually active. So yeah, there's basically a slide to highlight that it is common, but there are lots of things we can do about it, and hopefully this presentation will talk more about what physio can do. So urinary incontinence. Urinary incontinence is kind of defined as an involuntary leakage of urine. And this can commonly happen with stress. And I don't mean kind of emotional stress, but I mean as physical stress. So an increase in intra-abdominal pressure, which would be something like sneezing, coughing, lifting something heavy, running, jumping, those kind of activities. Often probably heard in the media about women that go on trampolines after having babies and having urinary leakage, and that will be classed as your stress incontinence. The other most common type of incontinence is urge incontinence. And this is leakage that you have when you have a strong desire that you need to empty your bladder or go for a wee. So this most commonly happens when people see a bathroom, or they put the key in the door on the way home, or they think about needing to wee. It's very common to have leakage at that time. Often people have a combination of both stress incontinence and urge incontinence, and therefore we would term this as mixed urinary incontinence. Usually there'd be one predominant symptom, so it may be that you have both, but you have more episodes of urinary leakage when you sneeze or cough, or it might be that you occasionally have leakage when you sneeze or cough, but you do leak quite often on the way to the toilet. It's common, but not normal. So that's a really important statement, I think, because like we said in the last slide, 1/3 of women experience these symptoms, but it's not something we should be putting up with. So there's lots of Tenor Lady adverts or different brands of adverts selling their continence products, and often they don't tell you that there are things we can be doing to improve these symptoms, and it's not something that's an inevitable part of aging or an inevitable part of going through menopause or having surgery. So definitely should be seeking help. Lots of things we can do to help these symptoms, and I'll talk more about how to do pelvic floor exercises later. But yeah, there's, don't suffer in silence, basically, is my take-home message there. 20% of women give up these activities they enjoy, whether that is exercising or going out seeing friends socially, because they're worried about leaking. I'm going to talk more about overactive bladder because this is a really common group of symptoms. So it's an umbrella term which kind of encompasses the urge urinary leakage, the increased frequency, so needing to go to the bathroom more common than not, the getting up at night to empty your bladder, and then it may or may not be accompanied with urge leakage, so that leakage on the way to the toilet or with the desire that you need to go. We need to rule out that these symptoms are caused by an infection or any other pathology, first of all. And if we are able to rule those out, usually it's the muscle in the bladder, the detrusor muscle, that becomes slightly overactive. So by that, I mean that bladder muscle will contract, giving you that sensation that you have urgency without the bladder muscle or without the bladder being full. So ideally, we want to wait until the bladder has a good volume of urine before we get those kind of more severe urges that we need to go to then empty. But with overactive bladder, we get that sensation quite quickly that we need to rush to the toilet, and then we may or may not leak on the way. So often it's that kind of frequent going to the bathroom, and then when you get there, you find there's only a little bit of urine left or there. Often, I've said before, the most common kind of things are when you put the key in the door on the way home, or when you see the toilets, you manage to get all the way there, you close the bathroom door, see the toilet, and then leak at that time. And that's that kind of bladder contracting a little bit too much without us having that time and that control. There are some common triggers, so things like caffeine, I'm sure we've all experienced before. Not everyone has a caffeine sensitivity, but lots of people do. So if you find that you have bladder urgency or urge leakage after having coffee or tea or lots of caffeine in the diet, then it's definitely something worth excluding. And the guidelines recommend to try a 2-week period with a reduction of caffeine, whether that's going down to 1 or maybe 2 a day if you're having lots, or whether it's cutting it out completely and just seeing whether that has an effect on your symptoms. There are other common bladder triggers like fizzy drinks, alcoholic drinks, very spicy foods, chocolates, acidic things like juices, apple juices, lemons. Not everyone has all of these symptoms, but if you're finding that you may have specific triggers, it's definitely worth excluding those things and then just seeing if that improves your symptoms at all. So there's other things we can do in terms of bladder retraining. So this is where we try to retrain that bladder to allow our bladder to fill a little bit more or to a good volume before we're getting that contraction of the bladder muscle, the detrusor. And this is something that takes time. So it's not that we give you a bit of advice and you go away and 2 weeks later the symptoms are kind of improved massively. It takes at least 6 weeks of doing regular strategies to try to improve the amount of urine that your bladder can hold and improve the control that you have. And we would always want this bladder training to be individualized. So we'd often get you to fill out a diary for us over the course of 3 days, where you document everything that you're drinking, everything that's coming out. So every time you go for a wee, weeing into a jug and documenting that volume for us so we can see how much you are actually able to hold. You would also document any urge symptoms. So that feeling of, do I need to rush a little bit or do I need to actually go right this second? And that's really important information for us to kind of make a bit of a plan with bladder training. Pelvic floor muscle training is really helpful. So often the pelvic floor, if we're able to activate these muscles well, it can defer that need to go. So it can reduce that contraction of our detrusor muscle. And that can be helpful because it can give us more time and control to go to the bathroom. So having that improvement in pelvic floor muscle strength and coordination can be really important. Lifestyle changes. So for example, if you are overweight or carrying extra weight, if you are smoking, and we know that nicotine can affect and be a bladder irritant, then there are things to cut out. And that's usually the mainstay of treatment. So first of all, we would try those lifestyle changes, avoiding the bladder triggers, and then going on to try bladder training and pelvic floor muscle training. And lots of people do have really good results. It does take time and compliance, but often people do have really good symptoms. I had a woman recently, and her big goal was to be able to pick her grandson up from nursery, get home in the car, get inside the house without leaking. And she was really good with doing these strategies. And she was really pleased when she came to see me a few weeks ago to say that she was now able to come in, take both of their coats off, put the kettle on, and then go and empty her bladder. And that was a meaningful improvement for her. So you can get good improvements, but it does take time. There's lots more I could talk about with that, but I'm going to leave it there for now. So prolapse. I think prolapse is a really scary term. And before I specialised in women's health, when someone said the word prolapse, I would imagine kind of all sorts of things hanging outside of the body in a way they weren't meant to be. And I think it can be quite a scary word. But prolapse, what it means really is a descent of one or more of your pelvic organs. And this doesn't necessarily mean descent all the way outside of the vagina or the rectum. It can be inside, just having symptoms of kind of heaviness, a sensation of a bulge or a lump or a dragging sensation. Occasionally, or sometimes people can have difficulty with emptying their bladder fully, or a sensation of difficulty emptying their bowel. And some people do have pain with sex and low back pain associated with prolapse symptoms. There's a whole range of prolapse. So some people just have a mild prolapse, and some people do have more severe prolapses. But often physiotherapy can be very helpful at reducing these symptoms. So we like to use the dry dock boat theory. So you can see on the slide there, I've got two different boats. The first boat has got support of water. So if you imagine the boat itself is your pelvic organs, so bladder and bowel and uterus, unless you've had a hysterectomy, in which case it'll be supporting the top of your vagina. The ropes there are your suspension, and they're your pelvic ligaments and connective tissues. And the water is your pelvic floor. So you've got your pelvic organs supported by the connective tissue and the ligaments, and then supported by your pelvic floor muscles from below. In picture B, you can see that there's no pelvic floor, so there's no water in the dock, and therefore the weight of your pelvic organs are pulling down on the connective tissue and the ligaments, and therefore likely to have prolapse symptoms. Now, if we put the water back in there, we can see that there'll be more buoyancy, there'll be less strain on those connective tissues, and therefore less prolapse symptoms. And that's basically how pelvic floor muscle support can help improve these symptoms, is that once you've got strain in that suspension, we're not able to change that unless you have surgery, but we are able to improve those symptoms by strengthening your pelvic floor muscles from below. So not everyone does need to have surgery. Physiotherapy can be really helpful at reducing these symptoms, and it's the symptoms that we're bothered by. The prolapse itself isn't dangerous or hazardous. We just don't want you to be putting up with these symptoms if they're affecting your quality of life and are causing bother. Just like the kind of overactive bladder symptoms and the stress leakage symptoms, it's always based on what it is that is bothering you in day-to-day life, which symptoms are bothering you, and therefore our management is always guided by that and what your goals are. And I'm very well, this is a bit of a whistle-stop tour. So, okay, moving on. So sexual dysfunction, again, it's a massive topic that we could do a whole presentation itself on, but usually sexual dysfunction will include pain with sex and having painful intercourse, but also having difficulty having penetration. And that used to be termed vaginismus, but we're kind of coming away from using that term a bit at the moment, and instead kind of putting it under that umbrella term of sexual dysfunction, because often these symptoms come together. A survey that was done recently reported that 7.5% of British women reported having painful sex lasting more than 3 months. So it's actually quite a big proportion or percentage of the population, and that was just people who responded to the survey. So I'm sure the actual incidence is much higher than that. And obviously this has a big impact on quality of life and relationships and lots of other things. So again, it's something that we want to be able to help with, and not just to be putting up with these symptoms. We will kind of put it into two categories with sexual dysfunction. So we've got primary and secondary. Primary would be if you've got a history of always having pain with sex, so you've never had pain-free sex. And secondary would be that it's something that is developed at a certain point during your life, and previously you have been able to have pain-free sex or pain-free intercourse. So with secondary dyspareunia, which is the term we use to describe painful sex, often it happens after either an infection or surgery or menopause or after childbirth. So there's usually something that triggers the onset of having those symptoms. It's important that we find out exactly where it is that you're getting the symptoms. So is it that it's more the tissues from the outside, so what we call more the superficial pain around the entrance to the vagina, or is it a deeper pain inside the vagina in a specific area, or is it kind of more generalized? Is it everywhere inside, or is it a specific area? So we do ask lots of questions as to the onset of when you've got these symptoms, where exactly it is, and how it's bothering you. Often when we have a history of pain, the pelvic floor muscles, instead of being weak, which we've talked about lots in the rest of the kind of symptoms, often these pelvic floor muscles can become overactive. So they sit slightly higher at rest. And then when we have kind of repeated episodes of pain, we have a fear regarding sex, and those muscles become more overactive, and therefore there's often more friction, less natural lubrication, and therefore we're more likely to have pain again. So it becomes a bit of a cycle, and we need to try to break that cycle in order to get improvements. With pelvic floor muscles, just like any other muscles in the body, we can relax them. So if we've got a particular area of overactivity, we can do desensitization, or what we call down training, to try to reduce the activity of some of these muscles. It might be that the muscles are not sitting high at rest and not overactive, but you've got an area of pelvic floor that has become sensitized. And this is something that happens when we've had pain for a long time. It's almost like those nerves, the more they feel pain, the more they become better at sending those signals to say that we have pain in that area. And if that's the case, we need to do desensitization, so where we retrain those nerves, similar to with the bladder training for overactive bladder, but we're trying to retrain those nerves to what normal sensation is, and that touch or penetration to that area shouldn't be painful. Often pain with sex or difficulty in having sex is associated with fear, anxiety, and a huge kind of psychosexual component. And it's really important that we identify those feelings as well. And often we work very closely with psychosexual counsellors and doctors. And it's definitely a multifactorial picture. So it's not that we're just focusing in on physio, and there's lots of other important parts as well. After surgery, lots of people worry about changes into their anatomy and shortening of the vagina. And I think it's important to remember that the vagina is very elastic. So it has the ability to change in size when we're aroused, and therefore there shouldn't be a difficulty with having sex and being able to have sex. So it's definitely something that we look at if it is a problem, with trying to do some specific exercises, whether that's the desensitization, so retraining those areas, or whether it's getting you to activate your pelvic floor and to relax. And sometimes we use dilators and other things so you can access those muscles a bit easier. So again, that was a bit of a whistle-stop tour. I'm very happy to answer any questions there as well. So just a quick note on bowels, where we've kind of ignored bowels so far, and they obviously are very important because they sit so closely to our bladder and our vagina and our pelvic floor. If you find that you are very constipated, then you're likely to be putting extra pressure on your pelvic floor muscles when you're trying to empty your bowels. And that's going to cause weakening of those pelvic floor muscles over time, because you're almost pushing against them when we're trying to strengthen them and getting them to work really well. So if you're finding that you've got difficulty emptying your bowels, you're finding that the stool is very hard, then it's definitely something worth considering. You'll see the little picture at the bottom there, which has got a picture, or it's got a block underneath the feet to raise the knees higher than the hips. And that is the position that we should all be going to the toilet in, because it helps to relax one of the pelvic floor muscles called the puborectalis, which is what I was talking about earlier on when I mentioned the anorectal angle. So apologies for using these pictures, but I think sometimes it is quite helpful to visualize. So I can't really pinpoint, can you see my mouse? No, I don't think so. You'll see the pelvic floor area that's written as a puborectalis muscle contracted on the left-hand side of your screen, and then it relaxed on your right-hand side of the screen. So you can see that it'll be much easier to pass a bowel movement or a stool on the picture on the right-hand side, because that muscle is relaxed, and so there's less of an angle to push against. Now, when we sit upwards in an upright position, that muscle, that puborectalis muscle, is automatically going to be contracted in most people, and therefore it will maintain our continence and stop us from emptying our bowel. But when we do want to empty our bowel, we need that muscle to be able to relax. So by using a stool and having your knees just slightly higher than your hips and relaxing your elbows onto your knees, that will help relax that muscle. And so it should feel like it's easier to go, easier to feel satisfied after going, and less likely to have to kind of push or strain. So definitely recommend getting a stool. I know lots of people worry that when they have guest rounds and things at one point in the future, you'll worry, but there's lots of nice ones you can get on the market. There's some nice wooden ones that you can use to put plants on at other times and things. And yeah, definitely something I would recommend if you are struggling with emptying your bowels. The other thing the bowels really love is a good routine. So having 3 regular meals a day is really helpful, because the bowels are most active about half an hour after a meal time. So if you're kind of finding that you're snacking or eating small amounts regularly throughout the day, it may be helpful to think about your diet, the regularity of that, and get into a bit of a routine, as well as drinking a good amount and making sure you have lots of fibre in your diet as well. Again, it's a massive topic, so just wanted to highlight that, you know, bowels are important as well, and we haven't forgotten about them. So why physiotherapy? So all of the things I've mentioned are symptoms or collections or groups of symptoms that physiotherapy has good evidence to improve. So whether that's leakage from the bladder with sneezing and coughing and exercise, or whether it's a feeling of having to rush to the toilet, in the guidelines as kind of physiotherapy is always our first port of call, and that's because it's least invasive treatment. And it has great evidence, but it does often need to be supervised. So just giving it as blanket advice often isn't very helpful, because we need to make sure that you're happy and confident with what you're doing. So you're exercising the right muscles in the right way, and it's specific to what your symptoms are. So it's goal specific, and also that you're kind of staying on top of it. So often you see a physio, do the exercises I know for a week or a few weeks, and then you drop off. So having that contact can be really helpful for motivation, because often these things do take time. It's not something that you can do a few exercises of a few weeks and expect improvements. And that's often why people who don't stick to them find that things don't get better. It's just a case of not staying motivated enough, which is difficult. There is some evidence to suggest that lots of people, when they do a pelvic floor exercise, actually don't do it properly and instead bear down. So in the next few slides, I'm going to talk through how to do your pelvic floor exercises and what's important to look out for as well. If anyone wants a copy of any of those bits of evidence or guidelines, then I can definitely provide that. So just let me know, and I can send that out with a presentation as well. Sometimes I think it's nice to be well informed as to success rates and how things can be helpful. So pelvic floor muscle training, how do I do a pelvic floor contraction? So going back to our model at the beginning, we've got all that pelvic floor tissue. The bulk of the muscle sits at the back of the pelvis, so it sits nearer the back passage. And therefore, the best way to exercise these muscles is by starting at the back first. So imagine that you're in a waiting room and you need to pass wind, and you're trying to stop yourself passing wind at the back. And then you're lifting through to the front as if you're trying to stop any urine from passing at the front. So we're looking for that back to front movement. Don't worry, everyone is slightly different. So some people do feel more sensation at the back, and some people feel more at the front. But you're trying to focus on that small back to front movement. Some people like the analogy of the zip, so the zipping of back to front, and others like to think about an elevator. So if you imagine an elevator starting at the back and coming lifting through to the front, so that kind of upwards movement towards your pubic bone at the front. Others like to imagine a droplet of water. So imagine a water landing in a pond and that rippling out effect. Instead of that, that's the relaxation element. You're wanting to focus on the opposite, so the reverse movement, so the water kind of lifting upwards. And that's what you're looking for with your pelvic floor. One of my old colleagues used to describe smuggling a diamond, and that lots of women like that one. So it's really whatever works for you, but try and think of those like visual strategies to help you with your technique. In the pelvic floor muscles, there's two types of muscle fiber, just like any other body, muscle in the body. So we've got our fast twitch fibers, which are really important when we need to sneeze, cough, or laugh. And we've also got slow twitch fibers, which are really important for supporting kind of long-term endurance, so supporting those pelvic organs. So it's important that we do both exercises. So therefore we do fast contractions and long kind of endurance holds. So for our endurance holds, you're squeezing and lifting, and you're trying to maintain that contraction, making sure that you're not holding your breath, you're not using bottom muscles, the bigger muscles in our bottom, so the gluteal muscles, and you're not using your tummy muscles. So you're maintaining that contraction, and then relax. And the quick ones are a quick squeeze, relax straight away, quick squeeze, relax straight away. So it's important that we're able to do both. Some people find one harder or easier than the other, so that's fine. Just work on the ones that you find more difficult, because that coordination and the ability to feel the switching on and the relaxing is really important. Might as well try now. So if you're sat in a chair and you've got good support behind you, sit right back so your back is fully supported. And I want you just to think about lifting at the back passage, lifting and squeezing through to the front. And you're going to try and do some quick ones, so those quick squeezes and relaxes, and also the longer holds. With the long holds, if you imagine a lift that comes up to the 6th floor of an elevator, you're not always wanting to come to that 6th floor. So it's not a maximal contraction. Maybe try to imagine coming to a 3rd or a 4th floor, and therefore it will be much easier for you to maintain that contraction and hold there. So try the both. It's worth mentioning that the relaxation is just as important. So after every squeeze, really do give yourself a good 4 or 5 seconds to fully relax these muscles before we squeeze again. So there's no point in kind of squeeze and not fully relaxing, because the muscles then have less movement. So you want to squeeze up here and then relax all the way down to the bottom. So then you've got that full range of movement when you next squeeze as well. Now, because I can't see you, I can't really give any hints as to whether anyone's doing them properly or not, but I shouldn't be able to see any movement. So if you're feeling that you're moving up and down the chair, or you're holding your breath or tensing tummy muscles, then you probably just need to give it a bit more of a go in a more relaxed position, whether it's lying down or making sure that you're fully supported. You want to be able to talk out loud so that you're not holding your breath. So in terms of pelvic floor muscle exercises, how often do we want to be doing them? The evidence suggests that we need to be doing them 3 times a day, and it will take at least 3 or 4 months to get that kind of optimal benefit. So it is something that we have to really stick to. There's no point in every time you do these exercises doing 1 or 2 squeezes and then leaving it till the next day, because we know from other areas of physio and general muscle physiology that we need to get these muscles tired and fatigued in order for them to get stronger and to improve in function. So each time you do the exercises, you're wanting to be able to isolate these muscles and get them working until they're tired. So that's going to be individual, dependent on what your muscles are doing at the moment. So whether it's doing 10 seconds, 10 times, followed by 10 quick ones, if you're really good, or it might be starting off doing 2-second holds and repeating that 6 times and until you're getting that endurance is developing and you're able to hold for a bit longer. So it's very individualized based on what you're able to do at the moment. But the general principle is that you need to get those muscles tired. 3 times a day, it can be any time during the day, whatever fits into your routine. So whether that's with meal times or whether it's when you're waiting for a kettle to boil, brushing your teeth, I think is a big favorite. whether it's when if you are commuting at the moment, and when you're sat down on a bus or you're at a bus stop. I see lots of things about women at bus stops always doing the pelvic floor exercises or waiting for tubes. It really is just what works for you in your routine. Some people like to use apps, and there's a really good NHS recommended app called Squeezy, which sends reminders and progress graphs. I think it costs about £2.99, and you can put your individualized exercise program in there as well. So for example, if you can hold for those 2 seconds or 3 seconds, whatever it is, you can pop that in that app, and you can see your improvements as well. Stickers, so good old-fashioned method, getting a nice set of stickers, popping them in different areas, and every time you see a sticker, you do your exercises then. So there's a few different ideas. I'm sure there's lots of other ones I haven't thought of, so let me know. Think about positioning. So you can do your pelvic floor exercises in any position, whether that's sitting, standing, lying, or I've got on that little picture at the bottom, lots of other positions you can do them in. As long as you're isolating these muscles and you're feeling that they're switching on, then feel free to do it in any position. And actually standing is probably a bit more functional for when you need to use your pelvic floor muscles in day-to-day life. For example, if you're out and about and you sneeze and cough, or you're feeling like you need to empty your bladder, we need to be able to use those muscles in those standing positions. If you're finding that that's very hard at the moment, then just do it sitting and lying. It's much better that you're using the right muscles and you're doing it effectively than you're doing it in a really difficult position and you're just tensing up lots of other muscles around the bottom, pelvis and tummy. So if lying down where you're fully supported with pillows and cushions is the only way you feel that you get a good activation, then just continue doing it and lying down until you're ready to progress to other positions. Make it functional. So if you're someone that's really active and you're doing squats and things, then exercise or activate your pelvic floor at the top of a squat, do your squat, and then relax when you come up to the top. So just make it functional for your day-to-day life. If you're lifting shopping bags or whatever it is, if you've got an active job, then try to activate your pelvic floor muscles with those activities for support as well. And that will be more individualized for your needs. So feedback, I always get asked this question, is how do I make sure I'm doing the exercises properly? So one thing you can do is just sit on a hard surface and have a bit of hard pressure on your perineum. So that's the area between your vagina and your back passage. Sitting in that position, you should feel that when you squeeze your pelvic floor, a little lift from the seat below, or you can even imagine that you're sitting on a tissue and you're imagining lifting that tissue from the seat and dropping down below. So having that feedback from a chair or seat can be helpful. You can insert a finger and you should feel a squeeze or a lift, or you can do it during sex as well and have feedback that way. If you're unsure that you're not doing it properly, then definitely seek a pelvic health physio assessment. And I'll talk about how you can get that referral or assessment later on. But don't keep doing these exercises, finding that you're not improving and just worrying whether you're doing it right or wrong. Definitely see a professional and get some feedback that way. There are lots of devices on the market that people use. There's nice fancy ones like the LV, which are lovely devices, but quite expensive. You're not going to have any better you're not going to have a better pelvic floor by using these devices, but they can be really helpful for getting into a good routine. So you've bought a nice device and you're wanting to use it, and therefore that can be helpful as motivation. Also, sometimes having something there can give you a bit of a feedback because you can feel that pelvic floor lifting against something and then fully relaxing. So it's very difficult to give individual advice, but kind of overall, using a device isn't going to get you a better pelvic floor. You need to be activating those muscles, but for some people, they can be really helpful for motivation or for sensation, depending on what your specific goals are. So what to expect from coming to see a women's health physio, or if you need a women's health physio referral. So initially we will ask lots of questions. So sometimes that's all we do for a first appointment, is we just find out lots of information about your bladder function, your bowel function, your past medical history, including gynae history, what your symptoms are when they started, how much they bother you and affect your day-to-day. So it is a lot of questions, so do be prepared. It might be helpful to write down things before you come and see us, so you got a good idea in your head of what it is that is bothering you and how often it's happening. Often we do get you to do some questionnaires either before the appointment or during the appointment, so we have a good baseline measure as to what your symptoms are. Sometimes an assessment can include a vaginal or a rectal examination. So we're using a gloved finger to assess your pelvic floor muscles, so we can give you that individual feedback as to what your muscles are doing, how they're working, and give you more of an individualized exercise program. This is always something we discuss with you, and it's absolutely always your choice. We don't have to do that, but it does mean that we can individualize the assessment a little bit more, so we can give you a bit more feedback. We can also just look externally without having to do anything internally if that's a problem, but it does give us a bit more guidance as to what your muscles are doing. As I've said throughout, the treatment is always individual, dependent on what your symptoms are and when they're bothering you. So if you have specific goals in mind, short-term goals, long-term goals, it's what is meaningful to you, what's a meaningful improvement to you, and that's what we're working towards. So what else do we do? So it's not all about pelvic floor training. I had another physiotherapist who specialises in musculoskeletal physio come and observe me in clinic the other day, and she left and said, I didn't realise you did all of that. And I kind of said, what did you think we did? And I think she thinks we just sit and talk about pelvic floor muscles and pelvic floor exercises all day. We do a lot of that, but we do a lot of other things as well. So I've mentioned bladder training and fluid management. So that would be for symptoms of urinary incontinence, particularly more the overactive bladder symptoms. And we would get you to do that bladder diary, so we can give you that individual feedback on how much to be drinking, when to be drinking, and also advice on how to retrain those bladder muscles to reduce that contraction of your detrusor muscle. The knack. So this is something that we call a pre-contraction of your pelvic floor muscle before you sneeze, cough, laugh, lift. So if you're finding that you're leaking with those specific exercises, we'd encourage you to be able to activate those muscles, which gives you a bit of a kink in the hose pipe. So if you imagine your urethra where we pass urine is your hose pipe, and your pelvic floor muscle sits through that, when we activate your pelvic floor muscles, it puts a bit of a kink in that hose pipe, and therefore prevents or stops leakage happening at that time. We do need to have a good functioning pelvic floor for that to be effective, but that can be really helpful. Biofeedback. So this is a big term that basically means having feedback from what those muscles are doing. And there's lots of different ways we can do that. It can be, like I mentioned, sitting on a hard surface and having feedback that way. It can be having something internal, whether that's a very simple device. Often we use vaginal probes that have a stick coming out. And when we activate the pelvic floor muscle, that stick moves a little bit. So you've got that visual feedback. There are much fancier devices on the market. So things that there's sometimes games you can play. So you have like almost like a little play boy that kind of things move when we activate the muscles and relax the muscles. So just anything that is giving us some feedback as to what's happening with those muscles. And that can be really, really helpful and valuable. Electrical stimulation. So we get asked lots of questions about this. It's not something that is appropriate for everyone. So it is usually a vaginal probe or an anorectal probe they would insert inside that would give you a bit of an electrical impulse to help stimulate those muscles. We would only use this if your muscles are quite weak or you are having trouble progressing. So you had either no ability to activate those muscles, or you found that the muscles, after trying to strengthen them on your own, were not improving and they were still quite weak. It's not a passive treatment. So we always would want you to be able to activate these muscles at the same time. So you're wanting to really try to work with the machine rather than just letting the machine do all the work. Pelvic floor down training and desensitization. So this is often what we use for conditions where there's pain, whether it's painful sex or kind of general pelvic pain, where we find that the muscles are overactive. We'd want to try some relaxation methods. That can be as simple as doing some breathing exercises and yoga stretches, or it might be more of an internal down training exercise where we get you to palpate the muscles or touch the muscles inside, either using your fingers or using dilators or something similar. Desensitization is slightly different. So we're just trying to desensitize those nerves. And that can either be by doing some external work, looking with mirrors, or again, it might be internal, working either with your finger inside or a dilator. We would always assess that first and make sure you were happy and confident with how to do those things and that it was safe to do so. Lifestyle interventions I've kind of touched on as we've gone through. So advice about appropriate exercise and safe exercise, advice about weight loss, and kind of general diet and smoking cessation. All of that comes under the umbrella of physio. So kind of empowering you to be able to self-manage some of these conditions yourself with simple lifestyle changes. Well, I say simple, but some of those things are actually very difficult, but things that you can do yourself to help your symptoms. Defecation dynamics, so that basically means bowel emptying. So there's lots of things we can do to help advise on how best you can empty your bowels if that's a problem. And that's kind of a whistle-stop tour. There's lots of other things we can do, but ultimately I think the advice is that these symptoms are very common throughout the life stages, but particularly post-menopause, post-surgery, and we don't want you to be putting up with these symptoms. So do seek help if you think that from what I've said today, it may be helpful. So how to get referred? So you can get referred on the NHS by seeing your GP and requesting a referral to a local women's or pelvic health physio. They may be working kind of independently, or it might be that they're under a consultant. So it may be you're asked to see a urogynecologist first before being referred on to physiotherapy. In the private sector, there's lots of women's health and pelvic health physiotherapists. I think if you've heard of a good one that you've had a friend or someone recommend, and that's always helpful with word of mouth. There are directories which I find quite helpful for finding physios in areas that we don't have as much of a network with. So POGP directory, I've got the website at the end here. It stands for the Pelvic Obstetric and Gynecological Physiotherapy Society, which is our kind of special interest group. And if you go onto their website, on the front page, they have a Find a Physiotherapist tab, which is there. And you can put in either your local area or region or postcode and hopefully find someone to see. And Squeezy is the app that I mentioned earlier on, and they also, I believe, have a directory where you can find a local physiotherapist. If you do have any problems, then let me know, and we have some other special interest groups that I can request if you're in an area that you're having trouble finding someone. So I think that's everything from me. Here are some of the useful resources that we can send out as well. And that website at the top is the POGP website I mentioned with a directory on. And there's lots of information available on there that you can download as leaflet format and save to phones and things, which I think is quite nice. So I'll provide that so you can access those things. And that's everything from me. So I'm sorry I probably overrun a little bit there, but do let me know any questions that have come through.
Thank you ever so much, Katie, for such a comprehensive presentation. I'm sure everyone's found that really, really useful. So in terms of, we've got a few minutes for questions, but if they start to, if the build up and we don't have quite enough time, then we'll forward them on to you. So the first question that we've had is whether the pelvic floor muscles can actually get overworked. This person sort of describes having been given exercises some years ago and to be doing them a few times a week, and but still experiencing some episodes of leakage, and what you think could possibly be be happening there.
Sure. So yes, just like any other muscle in the body, we can have weakness in your pelvic floor muscles, but we can also have that overactivity. If you're just doing those exercises every now and then, it might be that we're not working them enough for your kind of function. So did you describe kind of a certain exercise? Was it, I can't remember exactly what the exercise was. I think it was jumping or something that you're experiencing.
Yeah, I think it's that they were sort of seeing a physio for another reason and were given pelvic floor muscles to do, but I don't think we have any details about exactly which pelvic floor muscles they were doing.
So I think it might be a case of we're not working those muscles enough. So if you're doing it every now and then, we might need to get that muscle to the point where it's really tired in those kind of functional positions. So whether it's in standing or in sitting, whatever it is that when you're getting those symptoms. If you're doing the exercises and you're finding that you're still getting symptoms and it's not improving, then it's definitely worth seeing someone so we can give you a bit more of that individual feedback based on what your muscles are doing at the moment. Particularly if you have been trying yourself first of all. But yes, they can become overworked, and that relaxation is just as important. So every time you squeeze that muscle, make sure you give yourself that time to fully relax as well.
Thank you. And we've got another question about, I don't know whether this falls within the remit of women's health physio, but requesting any guidance for managing genital lymphedema in addition to compression tights and pants. Is that something that you think you can speak to?
I actually don't have a huge amount of experience in managing that. I would definitely say that's something that we don't want you to be putting up with. So definitely see a specialist nurse who would be able to provide a bit more guidance on what appropriate garments and things would be useful. Yes, I don't have any specific recommendations from my point, I'm afraid. But if you have the question, then send it over and I can find out for sure.
Oh, that's really kind. Thank you ever so much. I think that's all of the questions that we've had in so far, and I mean we've got a few minutes until 5:30, so perhaps we'll just sort of give it, you know, a minute or two more to see whether anybody else does want to ask anything further. Katy, is there anything? I know you mentioned a few points in your presentation that this was an overview and that, you know, you could speak for longer on some of these topics. Is there anything that you think it would be useful for you to add just in these last few minutes that you haven't had time to get to?
No, I'm sorry that it has been such a whistle-stop tour, and I can imagine that you have it's a lot of information. So I'm sure there are lots of questions to come, or things to think about. But I think essentially my main point is that the symptoms are all really common, and if you kind of look at anyone walking around the streets, lots of people are putting up with these symptoms that affect kind of general ability to do the things we want to do in life. So definitely don't put up with these symptoms. It's always helpful to try things yourself first. So definitely try doing pelvic floor exercises as a first instance, and think about general lifestyle. So whether that's diet and exercise, maintaining a good BMI. If you notice that there are specific triggers, whether it's for overactive bladder, specific dietary triggers, or things that you drink that irritate your bladder, then of course try to exclude those things first of all. And if you are coming to see us, then it's definitely helpful to write down when you're getting these symptoms, and if you can identify any pattern or triggers or kind of instances when it happens, whether it's things in a certain position or a certain time of day, all of that information is going to be really, really helpful to help us guide a bit of a plan.
Okay, we have had a couple more questions come in. We've got a question saying, I need to get up to wee at least once or twice per night. Is that normal, or could it be a sign of an overactive bladder?
Sorry, I actually definitely meant to talk about this. Yes, so we would say anything once a night would be normal under the age of 65. Over the age of 65, it would be classed as normal if you were going twice a night. And I say that is quite vague, because actually if it's bothering your sleep and it's becoming a bit of a nuisance, then that's not ideal. Sleep is super important. So if it's something that's bothering you, then first port of call, try and think about what you're drinking at the end of the day. So try to reduce your fluid intake 2 or 3 hours before you go to bed, just having sips rather than huge drinks at that time. And you may find that putting your feet up and having that kind of drainage from ankles and feet down in the afternoon or in the evening may be helpful. That may help you go and empty your bladder fully before you go to bed, so that you're not getting up so much in the night. In the day, kind of anything between 4 to 7 or 8 times will be normal, depending on how much you drink, weather, climate, all sorts of other things. But you know, if it's that you're going regularly and you're going for small volumes, then that's bothersome. Then that's something we'd want to improve.
Thank you. I've got a couple more questions. We'll see if we can get to them, but if not, then perhaps we can, you know, answer them on email instead. But I've got a question: is it possible to tell the difference between vaginal dryness or pelvic floor weakness?
Yeah, really good question. The two often come hand in hand. Vaginal dryness is one of the most common symptoms of the menopause, and usually it's one of those later symptoms. Often with a reduction in estrogen, we will have dryness, and therefore it may feel harder or more uncomfortable to engage your pelvic floor muscles, and alongside that you may have some weakness. So it's very difficult to say that they're two separate things. Often they come together. definitely see, well, try natural lubricants and things first of all. So there's lots of things you can get on the market, either water-based or oil-based lubricants, depending on what's appropriate to use. If that's something that's not improving, then do speak to your GP about other options in terms of whether topical HRT is appropriate or not. And then using that, your pelvic floor muscles hopefully should feel like you're able to activate them more, or it should be a bit easier to be able to use those muscles. So yes, very common symptoms, both of them, but we want to deal with them both separately. So start doing your pelvic floor exercises. If that is limited by dryness and it feels uncomfortable, then we definitely want to address that as well. And you may find that actually, like, activating your pelvic floor muscles, the sensation improves because you've got improvements to blood flow to the area and things as well.
Thank you. And well, I think we've got one more question. Hopefully we've got time for before we finish, which is, how long should you do each group of exercises for?
Yeah, good question. So you've got the long ones and the short ones. You're just wanting to exercise them until they get tired. So I know that's really vague. In lots of our advice, we say 10 long ones and 10 short ones 3 times a day. But actually, if you're finding that on the 10th one, you're just bracing everything because it's really difficult, then there's no point in doing that much. So try and practice yourself, maybe after this. See how many seconds you can hold for comfortably. Make sure you relax in between. And then you just keep doing that until you get tired. I'd say for a maximum of 10. So if you get to 10, then perfect. And then do your 10 quick ones and repeat that 3 times a day. That would just be to strengthen. So if you're doing that and you've been doing it for a period of a couple of months and you're finding that things are going well, then we can go down to doing it once a day. And that would just be for maintenance. And we recommend that for women throughout all different stages of life. So once a day. And that would still be your long ones and your short ones. So as a guide, 10 long and 10 short, but really I hate saying that because it's very much on what you can do.
Brilliant. So thank you so much, Katy, again for coming to speak to us and for covering so much in your talk, and for answering everybody's questions. And thank you to all of you for joining us. And yeah, and that's goodbye from all of us. Thank you.
Thank you very much for having me. Bye.
Bye bye.
Thanks, Katy. Thank you, everybody. Bye bye.